morning, George.
Good morning, Dr. Bravissimo. Today it's a Monday chilly morning, not Tuesday. We have a great guest today, Dr. Lia Gaggino, and the topic on hand is going to be interesting. Our journey from KCMS to podcasting and everything else in between.
Dr. Lia, who I referred to as my attending during my intern year at KCMS, and I met at Bronson Hospital in 1989. Her laughter and kindness is something that you can't ever forget. I still remember her call to me while I was at the library at Bronson Hospital with a child that had a fever for more than 5 days. She tried to pin me. I said, please, it's Kawasaki's. I'll call Antonio, the Peruvian cardiologist. Little did I know she had only graduated from KCMS a year earlier than me. Welcome to the show, Leah.
Thank you. Those are very kind words, and that takes me way back.
Yeah. Leah, how's my hometown of Kalamazoo?
Very cold. It's very cold, and you would not recognize the development we've had. We have lots of apartments and young people. We now have our own medical school affiliated with Western Michigan University and lots of great new restaurants, including Jungle Bird, which offers sort of Cuban fusion.
Oh, wow. Wow. So to set the stage for those of you who haven't visited Kalamazoo, Kalamazoo is about 100,000 persons, or thereabout. It's a university town. It has Western Michigan University and Kalamazoo College, which has a tremendous reputation in Michigan. When I attended there were two large hospital systems, Bronson Hospital, that was very dedicated to pediatrics, and Borges Hospital, which is the Catholic hospital. And the driver of growth in Kalamazoo then was Upjohn Pharmaceuticals. They had their world headquarters and research headquarters right across from the hospital. So it was an amazing experience. You had all these clinicians, and once in a while they would get out of their lab and they come over and do rounds with you. It was a fascinating town. They had their own building. It was amazing. They just crossed the street and they would just do rounds because they wanted to keep their clinical skills. Also, it is a home of Stryker. Stryker is one of the world's preeminent orthopedic implants producer. And the medical school is named, I think, after Stryker. And they have one of the best orthopedic programs in Michigan because Stryker needs orthopedic training programs in Kalamazoo in order to test their new products. So it's a community like I've never seen in America. It's so small, but it's so highly intelligent and involved and kind. It was an amazing experience. Anyhow, I have something more important to ask you. How is baby George?
Oh, the best. Oh my gosh. He is 3 weeks old. He's gained 2 pounds since birth. He is eating like a champ. And I just get this incredible baby fix. I call it baby zen. I just can hold him and look at him for 2 hours, literally.
Mhm.
And it is like the best. And the other really lovely thing is seeing my daughter be a parent. She's just good, and she and her husband are just both chill, and they just love this baby. They waited 4 years for him. He is very special. And my mother is just, I love the name George. So
Oh, wow.
it's just the
Has
best.
your mother been able to come visit yet?
Not yet. My dad broke his hip, so he's doing rehab and can't really travel yet. Yeah. So there's that. Yeah, I've got the ends of the spectrum. I've got two parents that are in their 90s and then this lovely little baby at the beginning. So it's an interesting life trajectory.
Oh, is he going to be a patient at Rambling Roads?
He already is.
Super.
Yeah, it's really nice. One of my several of my partners, but Randy Dyke has seen him a couple times, and it's just really fun. My daughter's known him, and so it's lovely.
Oh, how amazing. I'm so glad you have that in your life.
Yeah,
Um,
me too.
Now, what was the genius of Michigan State Medical School?
It was born in the late 60s, so it's a young medical school. Excuse me. It's a young medical school, but they conceived of it as this kind of a place to develop people that wanted to go into primary care. So instead of having clinical rotations in a big university hospital, they farmed us out to community programs. And so they established these hubs all over Michigan. So there was Kalamazoo, Grand Rapids, Lansing, Saginaw, Flint, and then they had a clinic up in the UP, so in Upper Peninsula of Michigan. And our class was 100. It was the first class. We had 51 women. And so that was a milestone. And they sent us, so in groups of about 20, and we worked in community settings. And of my class, lots of people went into primary care, internal medicine, peds, and many stayed in the community. And I think that was the hope. We have also a big emergency medicine residency. So there were a couple people that stayed in that. And I think it was an interesting conception. The other was the style of teaching. They had track one and track two. And track one was traditional lecture, learn, take a test. And track two was small group, and they did it around problem focused groups. So we'd have one on jaundice, and you would learn everything about jaundice and from microbiology, the physiology, and you did it in a small group study. And I chose that because I had been an undergrad at Michigan State and I was a physiology major. And a lot of the professors that taught at the medical school also taught at Michigan State. So I thought, I'll try this other learning style. Still did some things in the traditional way, like anatomy and things like that. But it was an interesting learning concept. I don't think that exists anymore. I'm far from that. But yeah, so that's how I came to be a physician, was through that program.
The school got a lot of blowback, and so did its residency programs because it did not fit the style of the big universities out in the East Coast and the West Coast, right? And they were
Well, or at
constantly
University of Michigan, we had that in Wayne State, so big universities.
yeah. So the residency programs in the school was always like under a microscope because they had a
But
different.
it was definitely non-traditional, and the students were non-traditional as well. They joked we were the granola, touchy-feely hippies, and that certainly fit some of it, but we had a lot of older students. So one of my classmates was 40, and so that was a whole interesting dynamic as well. Several people were married and had kids, and so it was a very different experience. I was the only one I knew, but it was not traditional.
When I was there, there was, I think he was a runner. He had been in the Olympics or won an Olympic medal, and he was a resident. It was fascinating, the diversity of people that the program had and how tied into the community the program was.
Yeah.
Um,
And we had international medical grads in our residency program. We were small. I think there were 6 or 8 peds residents a year, which is a small program. And the advantage was I got to do a lot of stuff because we didn't have big teams. We didn't have fellows. And so if you assisted in a surgery, you were like the first assistant. And I remember as a medical student, the surgeon was doing an appy and said, "Here, you want to stitch and close?" I was like, okay. Actually, this is a fun fact. So my first suturing adventure was as a medical student. I had a teacher at Michigan State who did medical anthropology, and her study was in birth in 4 cultures and one being in Mexico. So I decided that I would go to Mexico in my pink overalls and backpack and hang out with midwives. And so I got to go around the country. I was in the Yucatan and I went to a little hospital, and there was a guy who had macheted his leg and had walked a long way. And they let me, I like to sew, so I have some skills doing that. But that was my first experience doing medical care. I'm not sure ethically that's okay. And I guess they supervised, but yeah,
I
so
guess it
that
was
was
either
my
you or nothing.
yeah, yeah. But anyway, so yeah, I think in a small program you get to do a lot. And Kalamazoo is a pretty sophisticated medical community, I think, as you mentioned, because we have the universities, and now Upjohn is now Pfizer. And in fact, the first vaccine rolled off, the COVID vaccine rolled off the presses, and the president came as the first trucks rolled out. So that's exciting, but we don't do everything in pediatrics. We don't have a transplant part program. We don't do like ECMO. but we do a lot in-house and really talented and skilled clinicians. So it's an interesting community in that way.
Do you remember that KCMS pediatric clinic down in the basement of Bronson Hospital?
Oh, yeah, nothing glamorous about that. And in fact, this is really crazy, but I had a patient who I took care of down in the clinic that followed me into my practice, and I ended up taking care of his children through graduation from high school.
Oh, what sticks in my mind, because I came up from a very academic program, and the National Hospital for Children in Costa Rica is extremely academic. Outpatient doesn't really exist, at least not at that time. And it was a fully functioning pediatric office. It opened at 9 in the morning and closed at 5, Monday through Friday. And there were well child exams and sick visits all day long. And the medical students or the residents would go and take their turns with an attending and seeing patients. When I went to Rush to finish my residency, I went to a quote unquote continuity clinic, which was a joke. It only existed half an afternoon with a visiting person who was in private practice for each afternoon, and you saw 2 or 3 patients that were there for their vaccines, but they didn't really see the office as their primary care office. And that clinic was amazing before the government kind of got their nose and where it didn't belong. You had a microscope and you could do microscopy on UAs, gram stains. We call, and George still does the throat cultures, but we also we did scrapings from the skin and put in this gold thing and see if the fungus would grow before we treated the kid for different fungal illnesses. We did urine cultures, but CLIA did away with that, and they took all of that lab away and had to be sent out to the main lab.
It's interesting because when I was an undergrad, I worked at Sparrow Hospital in Lansing and I was a phlebotomist. And so I got to hang out in the lab and I learned a lot of great skills like starting IVs and drawing blood. But I used to hang out with the med techs. And so I would look at urines and do that. So I actually would take these little tests so that I could do the CLIA wave stuff. So I continued to do for a long time UAs and KOH preps and in our office. So I was able to do some of those CLIA wave, non-wave tests
Oh
for
wow,
a long time.
George does them too, right? You do urine cultures and
Yeah, but we have a
both
clear
the
certificate. We're moderately complex, and it's a real pain in
Mhm.
the neck with lots of administrative books and protocols and policies and medical directors. For a solo practitioner, it's not worth it. That's why they don't do
Mm.
it. We have 2 large offices, 17 doctors, so there's volume, so all of a sudden it becomes worth it. And you know what? In-office laboratory does help with patient care. It does. Do you know how many kids over the years we found with leukemia on the CBC
Mhm.
that has leg pain that had been seen? Yeah, you got growing pains. It was leukemia.
Mm.
Simple CBC. It's stories like that. Epistaxis. Yeah, you're picking your nose. It was thrombocytopenia, platelets at 2. True
yep,
stories.
yep, yep. And Leah, why do you think more programs, especially with the shortage of primary care, it's not just pediatrics, internal medicine, family practice, even some of the internal medicine subspecialists like endocrinologists, there's not enough of them. Why don't you think more residency programs are geared towards the community like MSU KCMS was?
Yeah, I don't know. And I listened to your recent interview with Ronnie, and I'm going to mess up his last name, but, and him talking about why people don't go into primary care. And I think the takeaway message from that interview that I heard was exposure. And I think for me, I actually thought I wanted to do OB. I had done this trip to the Yucatan and watched a birth in a hut by candlelight, and I had a friend that was a lay midwife, and so I did home births with her, and so I was a hippie, and I thought that's what I wanted to do. Then I did my rotation in OB, and I was like, "Yeah, things could go very wrong." And the OBs were not happy people at the time. No offense, they were mostly men. I think there was one woman OB, and the conversations in the OR were just they were just not happy people, and then I did my peds rotation. I'm like, these people are happy. They get to take care of kids. And so for me, it was Jake Weintraub was my attending, and he's really the reason I went into pediatrics. So I think it was that one-on-one experience in a clinic. And I started out at a peds clinic that was even smaller than that. It was just two docs. And I think there was so much hands-on that, and a lot of responsibility. As an intern, we ran the PICUs. And I remember having lots of conversations with my attendings in the middle of the night and having to make some big decisions, flying a kid to another institution who was on isoprel for his status asthmaticus. Okay, that's like leeches, right? but but those things stick in your head. And I don't know. I just think that there was the freedom to do a lot and feel like you could do it.
Yes, and I found it's probably not like this anymore, but Dr. Chavino idea of the big hospital and the community doctors being the same neighborhood. And we interviewed Dr. Coronia out there in Long Island. She has the same vision as Chuck did. And I found it fascinating how they had a layer of safety. There was always an intensivist on call, may or may not be in house, depending on the acuity of the PICU. Then a community doctor would do call in the PICU, and then the intern. And that was the team. It was an intern and the community doctor. And if there was an admission, Chuck would come in from home and, go over the admission with the two of us and then go back home, go back to sleep. To me, that was a great model because the community doctors were invested in the program, but they also didn't lose all their skills, which were
Mhm.
hard earned through a hard 3-year residency. And they were doing what they liked in the office.
On the other piece to that was we had an incredible nursing team, and the nurses, that would be my message to any trainee is make friends with and treat the nurses with incredible respect because they will save your butt. They know their stuff. And I would go on transports with them and the baby bus. We're in Southwest Michigan. So we would go long distances out to these little rural ERs and pick up kids. I even got to go on a couple of flights. We have a helicopter. It's actually a shared thing between the hospitals. And so that doesn't happen anymore, but the residents don't get to do that. But I got to go on flights and pick kids up. And I have to say, medicine, there were parts of it I really loved, but it was too anxiety provoking for me because I didn't know what was coming next. And the stakes are so high because of the acuity. And when I finished, they asked me if I wanted to still do some shifts in the ICU. And I just said, I don't think so. And honestly, for me, as much as I loved the relationships I had with the residents and the nursing staff, having hospitalists was a godsend because I loved the outpatient setting so much. And I felt like my skills were getting rusty. And I just felt like I wasn't the best person, that I couldn't be everything to everyone all the time. And my interest was doing mental health and they were happy for me to do that.
Yeah.
But yeah,
Yeah.
it's an interesting journey. You forget how much responsibility that you had, but to go on a run and you were it. You were the doc with the nursing team.
Yeah. Chuck Cavanaugh sent me on a, it was a snowy day. I'll never forget it because I felt like a rock star on the helicopter with John Rowlett. John Rowlett was the senior
Sure.
resident. And Chuck had all these things you had to do. He sent me to buy special boots. And I'm like, I don't need boots. He goes, yes, you do. John Rowlett had to land in the middle of a field and walk for half a mile because there was this storm that came out of nowhere and the helicopter couldn't fly. You need boots. So I got boots. And we went to, I don't remember which community hospital it was, to pick up a child with meningitis. And it's snowing like there's no tomorrow, and the helicopter's hovering. Oh, we couldn't land at the hospital. So the helicopter hovered over the airport while the two snowplows in town were going around in circles to open up a space for the helicopter to land. And then the snowplow went in front of the ambulance where we got onto the ambulance to go pick up the kid. We picked up the kid, rode the van, the bus back, got him on the helicopter, flew back to Bronson. And as we walked to the emergency room, the poor kid started seizing and went to ARDS. It was, but it was, I never thought in my wildest dream that I'd be in a helicopter in the middle of a snowstorm and people would be
Yeah.
plowing my path so I can get to help a child. So it's
Yeah.
great.
You have experiences like that. And there's one that sticks in my head. We went out to St. Joe, which is a little community on the lake shore, and was a kid who was jumping on a bed and aspirated something and stopped breathing. And the attending was with me and did an intubation, and the kid didn't make it. But when they pulled out the ET tube, there was the wadded gum stuck to the end of it.
Oh,
And that was such a sad, it was a totally healthy kid. But you get those kinds of experiences, and then you have you feel a sense of competency that you can take care of kids. And even in the office, I had a septic kid in the office, and I was able to start an IV. We used to have fluid, start an IV, gave him a push, gave him a shot of Rocephin because he was sick while the baby bus was on the way.
hey,
Yeah, I liked doing that. I like doing procedures, but my love is outpatients.
my recollection, of course, your memory is always jaded, but my recollection is that I saw so many head traumas with bolts in their heads, and Dr. Hopkins was a neurosurgeon.
Oh,
Mhm.
the best.
Oh, he was so funny. Oh, he was a great neurosurgeon.
Oh,
He was like out of central casting, tall, debonair man, and they would sit
always wore a suit. He'd come in at 2 in the morning, he'd have a suit and tie on.
and he would sit. He was funny. We used to dictate on a phone, and you would press a button, and he would sit in the ER admitting the patient and said, "And here we are one more time on a Saturday night with a fool who decided not to wear his seatbelt, went through the windshield, and now I got to repair his head. Why?" And I'm an intern. I'm like, he's not dictating. Then he would turn around and just chuckle. I'm not dictating that. I'm just fooling with all of you.
Yeah, he would when he was an adult neurosurgeon, but he let me go into a surgery. I had a kid that had a pituitary adenoma, and as a result had like pan endocrine issues. She had delayed puberty. That's how I picked it up. But I got to go into the OR and watch that surgery, and that was cool. But you got to do things like that because you had relationships with people. And John was a great guy, John Hopkins, and Don Batts, he was just a kick-ass infectious disease doc.
Yes.
So good, so brilliant, and he loved teaching. So good.
Yes. But is your recollection too that PICU had a lot of head traumas, or is it just that's what kept
I don't remember that specifically, but at the time, because when I was a resident, a lot of the peds care was at Borges because there was Borges Peds, and they had a big clinic that was affiliated with the hospital. And so they saw the bulk of pediatrics. Bronson was mostly the community peds did their admits. And then it flip flopped. At one point, I think there was some decision that Borges would keep inpatient psych and Bronson would be the maternal children's hospital. And so now Bronson has a dedicated true children's hospital. It's embedded within, so it's a floor, but we are part of the Children's Hospital Association. We have a PICU and a fairly good sized tertiary care NICU, about 40 some beds. So we serve a lot of Southwest Michigan, even though we have big systems to our north in Grand Rapids and to our east at the University of Michigan.
Yeah, the
uh,
children's hospital thing seems to be a thing. Now everybody's becoming a children's hospital. And unfortunately, a lot of the bread and butter pediatrics that used to go to the community centers have nowhere to go because
Mm.
they don't have ER physicians, they don't have wards. So they all get turfed, sent away to a children's hospital, which could be 45 minutes to an hour away.
Yeah, I think that the good part of it is just for us, it was the clinical guidelines and
Yeah.
some just the practice of care. And the problem was at one time, Borges they would have a sick kid on the adult ICU. And here's Bronson across town, 2 miles away, that had a PICU, and it just wasn't appropriate care.
Yeah.
And we had a dedicated PICU. And so that's how it's evolved.
And Borges has gotten out of maternal care too, of maternity care.
They just dropped it, actually. It's just not much of anything anymore. Back in the day, honestly, we used to cover both ERs, inpatients on both hospitals, and had to attend C-sections at both hospitals. So when you were on call, oof, I'd go into the ER and see kids, and there was something exciting about it, but it was also just grueling and exhausting. So I think you lose something in not doing that sort of intensity, but there's also some, I don't know, self-preservation to have it be different. So
What do you
I'm
think you
not sure
lose?
that
What do you think you lose?
there's just something about the doing it and knowing you can do it and that, I don't know, just being able to persevere. But I'm not sure that it's smart for somebody to make really life or in death decisions when you've been awake for 36 hours. I do think that there's people we're not superhuman. We get tired, we have families, all those things, but it is a different experience. So I'm just waxing poetic and getting all nostalgic, but it was hard. It was a hard life. Being a physician it's a hard job.
It's a hard job.
It's a,
Being a soldier is a hard job too. They go to boot camp.
yeah,
So we went to boot camp. It's called
We went to
Residency.
boot camp.
yeah,
So when the
yeah,
time is there, you know how to execute.
yeah, yeah.
If you don't go to boot
So,
camp as a soldier, when you go to war, you're finished.
yeah,
Yep. So I think what you lose is your critical thinking skills and your procedural skills. But what I miss most about not being part of a hospital today is the interaction with the Dr. Hopkins, right?
mhm,
Because I love pediatricians, but it's also a lot of fun to talk to the orthopedic surgeon
yeah.
and the neurosurgeon and the obstetricians. And we need that. We
Well,
need that as
yeah,
humans. And we've
it,
lost, we must send a message in Epic. That's not the same as picking up the phone.
no, and when I was a resident, I did my elective orthopedics because we didn't have peds or we had later we got peds ortho, but we didn't have peds ortho. So I did a rotation with an adult ortho group and I went to knee surgeries and all the things, but I really got to know the office well. And one of my Dave Christ was a resident with me from Michigan State. And what was great about it was when I was in practice, I could call their office and the office staff all knew me. And so we had those kind of relationships. And that was the fun part of doing that. And so you do lose that. I know we're hospitalists because we talk to them all the time. And nobody goes to grand rounds anymore. It
Yeah.
used to be all of us, that's where we saw each other.
Yeah.
Yeah.
Friday morning, 8 o'clock.
Yeah. Yep. And do you remember how Dr. Hare and Page took care of all the
Of
children
course.
with diabetes? That
Yeah.
was an
There was,
model.
yeah. Yeah. They were general pediatricians and Dr. Hare ran the diabetes clinic and there was a camp in the summer and he and Bob Page would do that. And Doug Homnick he trained as a pulmonologist, but he was our pulmonologist. Paul Haletko was our hematologist. And so a lot of the community peds had these other areas of expertise. So they really were able to use their skills because we just didn't have a big program. So that was the downside. There were things that I didn't get. Like at the time, we didn't have a hemonc program much. And so I never really learned that. I don't have to be a hemonc doctor to do primary care. I
You
mean,
know,
it's good to know about it. But
like,
so you can
how-
pick up the kids with leukemia for
yeah,
sure. You have to know your skills, but
yeah, leukemia is not a good thing, but I don't need to know how to do the chemotherapy or the bone marrow for it. I just need to know pancytopenia is not good.
yeah,
What I found fascinating is I'm what gentlemen, and when I say gentlemen, I mean what kind-hearted and honest people the pediatricians at Kalamazoo are. There was no problem with sending my patient to Bob Page for her diabetes. He won't
right.
touch urine infection in my patient. And I saw Doc Homnick in the clinic see the ear infection and say to the parents, "Yep, looks like you have an infection. Call your pediatrician, make an appointment. They treat ear infections. I take care of CF." And it was just such a, for the lack of a better word, gentleman agreement that you didn't poach, you didn't steal, you didn't talk poorly about another physician.
I was on a team that was working with it was Spectrum. It's now Corewell, but up in Grand Rapids and Helen DeVos Children's Hospital. So it's very interesting now. Michigan State has their clinical rotations and have a campus in Grand Rapids. And so this medical community has just exploded. But we had a lot of meetings with them to say, please don't take our patients. We need to keep our patients in our community, and what we have and what we don't, we recognize. And when we lost our rheumatologist, but I got to have really nice relationships with the folks up there too. And we had some interesting backups. Like we had Dr. Park from U of M who would do urology, and he would do a clinic, you know, once a month or once a week or something. I can't remember the frequency, but so we would fill the gaps where we could. And Bronson's an independent hospital system in the midst of these giants. So it's an interesting, we have 4 hospitals, and it's an interesting position.
So this, yeah, you just reminded me of something that doesn't happen anymore. But Antonio Piscara was a cardiologist when we were there, and he was at that medical mall that Bronson owned. That's where his office was. And he had a very close relationship with a pediatric cardiac surgeon at Detroit Children's. And Antonio would do the, what is this called when they put the dye into
The cats,
the cath? Antonio would do the cath in the adult cath lab, identify the lesion, get on the phone and talk to the cardiac surgeon in Detroit and say, I got a kid with this and that. You're going to need to take care of it. And then they would like FedEx the film for the cardiologist or the cardiac team to see it in Detroit. And he said, "Yep, that's it. I think you're right. Send them." It was amazing to me that we could do that before the internet. We shared so much and very close personal relationships built on trust. It was very nice.
there was a call number at the University of Michigan. I used to know it by heart, where you could call and talk to one of the attendings there. They called it the M line. They still, and it's still there, but I knew the operator because I would call and he'd say, "Hey, Dr. Gaggino, how are you doing?" And we would chit chat for a minute. And I'd say, "Can I talk to, I need to talk to the rheumatologist." And you would get the rheumatology fellow or attending on the phone, and they could talk you through. And it was great. Those relationships are what matter so much. And I do think, not to say there's no ego in pediatrics, but by and large, pediatricians are like the best people. In fact, a pediatric surgeon, Mike Klein, who's from Detroit, just a tremendous person. When he ran for AAP president, he gave this talk, and I literally started crying about how pediatricians are the best people in the world and so smart and so kind. And I did a podcast with him. Just, it was like my gift to you the first year I did podcasting. And it just was like, oh my God, I'm such a good person. And it just made me I love pediatricians. I think they're lovely people.
Do you
And
think with the newer generation physician, this relationship, this talking, it doesn't seem to want to exist anymore? For example, if we had a case that we had to send to the emergency room, we'd pick up the phone, call the ER doctor, ask for the attending, you give him a few words of what your thought process is. Oh, by the way, he's coming down your way. Now, talk to the secretary. You're sending us somebody, birthday, name. They don't even want to talk. It's weird. Sometimes they'll get on the phone by accident and they say, "Why are you talking to me?"
Yeah.
I don't
And you
know.
lose something when you know people, and because, and I've talked with my child psychiatry friends about, not that we have child psychiatrists in our ERs, but in big places like U of M, University of Michigan. And they said if the pediatrician called and said, "I'm sending this kid in with suicidal ideation, and this is just not like him. I'm really worried. I know this kid. This is different." And they said that makes all the difference. That would
Pay
really
a little
sway
attention.
them decision making. So I still called down to the ER. I still asked to talk to the attending. I still call teachers and therapists and talk one on one. That
We're
was
anomalies
my
these
style.
days. Anomalies.
Yeah.
How many
and,
times did I call the ER and say to them, "Hey, doc, I have this kid with, I don't know what he has, but good it's not."
Yes.
Right.
Yeah.
And interesting when we talked to Colleen's he basically an OB anesthesia classmate of George. And he said these newer anesthesia residents don't have any social skills. He said I'm not sure if they're anesthesia residents or they're in a psych ward. He said it's the most weird thing. They don't have any interpersonal skills. And I'm like, wow, maybe just that's what attracts anesthesiology. You don't have to talk too much to the patient.
At the end of the day, honestly, I think the art part of medicine is the relationships that you have. My favorite author, I just finished his book, Abraham Verghese. I love him so much. He's an infectious disease guy at Stanford. And he just writes these beautiful stories. One was about him taking care of HIV patients back when he was out in this rural area. He was an international medical grad. His job was in like West Virginia. And he kept getting these young men coming home from the coasts, California and New York, and they were sick and dying. But he talks about these relationships that he would do true hands on. He would come see this young man who was dying, and the young man would always open his shirt so he could listen to his heart. And he said it didn't make any difference in the care that I was listening to his heart, but it was the act of the laying on of hands. And I think that if we don't hang on that, you got to know your stuff. You have to be smart. There's no question about that. You have to know your skills. It's really important to know what you don't know. But the relationships with patients are what make a difference. My husband went through a really bad, he had a huge popliteal aneurysm and it clotted. And it was just a nightmare. This was 13 years ago. And everything that could go wrong went wrong. Grafts went down. They didn't have a graft in the middle of the night. Somebody had to drive over to Borchester to get it. Hospital shared. And one night the surgeon came out, Anton Sharapov, and he came out and he had tears in his eyes and he just said, I'm so sorry. This has been so hard. And in that moment, I trusted him with anything because I knew he cared about our family. And that's the stuff that makes being a physician rewarding. You have to do all the other crap. You have to document and all that junk, but I don't know. I call it the magic in the room. That's what it's all about, I think.
Do you guys
Yeah.
think that technology and cell phones and all these things, do you think that has become the impetus to caring? People become medical record numbers and you become a provider?
I think there's pluses and minuses. As much as I hated documenting in Epic all the time, it was really nice to be able to pull up the labs right there and
Yeah.
not have to call the lab to fax you something or
Yes.
to see reports and find things in the media tab and find what you needed and see the Billy chart graph. So I didn't have to do it myself and plot things out. On being able to look up stuff on up to date, that kind of thing. But I still pulled out my red book, the paper one. And no, I think that technology is what it is. And I think we just have to use it to its best purpose. But if we lose our relationships with other people, I think that's really unfortunate. And I think we have to make time to do that. If you're hunched over your computer at lunchtime and not talking to your partners, in practice, I would always go and have lunch back in the lunchroom with the
Right.
nursing staff. And it meant I had to chart late at night.
I think from my perspective, technology has wonderful things. We couldn't be having this conversation if it wasn't because of Zoom and the internet.
Correct.
Absolutely.
I talk to George 3, 5, 10 times a day, and it's mostly because we can text. It's not very
Right.
intrusive. If he's seeing a patient and I text him something about the podcast, he doesn't respond, I'm not offended. I know he must be busy in the clinic seeing patients, but we can have a very close relationship. I think what has, other than the laying of hands, which is extremely important, it's the drive for being super efficient. So when I was at Kalamazoo, Dr. Davenport was the one of the ID doctors, and I did a rotation with him, and the man was genius.
Yes.
But not only was he a genius, he was obsessive compulsive 10 times more than me. And he didn't believe anything, nothing. Like he would start the rounds at the lab, and the lab techs knew him, and they knew that he wanted to see the sputum of all the COPDers to see what it looked like. He didn't just want to read the report. And then you walked over to the radiology because there was no digital radiology back then, and he would look at the films for all his inpatients with the radiologist. And there was back and forth communication. The radiologist says, "I think this is that," and "That's not that because blah, 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 blah. What else could it be?" And that doesn't happen. Now, yeah, I can pull the image in Epic, but I'm not talking to the radiologist. I'm not talking about, no, this kid doesn't have pneumonia. He's not tachypnic. He's not febrile. His pulse ox is normal. Has to be atelectasis, or what else is in there that looks like pneumonia? And that has been totally lost in the name of
Yeah,
efficiency.
I agree. I used to do that too, walk down to radiology, and then I would learn a lot of stuff. We had an ultrasonographer expert in radiology, and I would go down, and she was so smart. I don't know how to read an ultrasound. And God, she was smart. I learned so much. And I knew if I needed a kid to have an ultrasound, I wanted to send it to Kathy because she knew. So anyhow, yeah,
I think
there's
that's what
waxing kind of nostalgic, but yeah.
that's what's missing. It's just with the drive for efficiency in a profession that there's a big component of art and a lot of uncontrollable variables because no two human beings are the same. I don't care if they're both white, 2 months old, born in Bronson, living with intact families in the same neighborhood. Those two kids are different. Um, and I think that is where the loss is. Anyhow, I wanted to talk to you about the relationship that you had because it's also very interesting to me as a very young physician how the relationship between, for example, Dr. Hartline and Chabonneau and the residents who then became the attendings, and how that experience is so different from many other training programs.
I just distinctly remember sitting up with John Hartline, who was just a tremendous neonatologist. And when I was on call, I would sleep at the hospital, and the neonatologists were in house as well. So we would just sit in the call room in the lounge on the NICU and just talk about cases. And it was just so collegial. He loved teaching. Chuck was a lot more intense, but they were there, and I think there was also this sort of time because they were in house, and we could just talk about things and got to be, I called them Dr. Hartline, Dr. Chabonneau. What was for me the big transition as being attending was calling them by the first name. That was the kind of the transition point to growing up, was to say,
Yeah.
"Hey, Chuck," or "Hi, John." But yeah, I learned a lot from those nighttime conversations, just when we're up worrying about kids and just having that hands-on-one guidance. It
And
was
what about in
definitely
the
that.
hospital? What about in a hospital today where you're Herb, I'm George, you're Leah, with the
Yeah, I,
nurses, with the cleaning people, with
I hate that.
it's
I
not
can't
good. I,
stand
I
it.
I
had one
haven't.
doctor, I have one doctor that was a resident at the hospital where we go to, and then she ended up being the hospitalist for the nursery, the well baby nursery. And she's trying to speak to the nurses, and they keep calling her by her first name, Kelly. And she doesn't understand why she doesn't get any respect from nobody. So she was
Eh,
a resident. Now she's a big resident,
Yeah.
Kelly. I told her, you
Yeah,
got to
to-
I never
say,
had that experience. I was always Dr. Gaggino, and still when I go in to pick up my meds in the pharmacy, and I know the pharmacy staff, and they always call me Dr.
yeah, but it's
Gaggino.
a
And
new thing happening.
so to me, it's not so much about respect, and this is why I'm really opposed to doctors wearing scrubs. It's about having some sort of consistency so that your patient feels safe. And I know the nurses hate it when I say this, and I didn't, not in the US, I did not practice at a time where nurses wore a cap and all white uniforms. But when you're in a hospital and you need help, and the cleaning person, the clerical person, the medical assistant, the nurse, the doctor, they all wear scrubs. You don't know who you asked. They all look like, and maybe you just want to know where the cafeteria is. So you're looking for someone that looks like a secretary because I'm not going to bother the doctor, but where's the cafeteria while my mom's here because I need a cup of coffee. But we're animals. We need some signaling that says, here's a person in charge. They look like this, not the color of the skin or your gender. They dress the part and maybe they wear a lab coat and people address them as doctor in the hospital because they want the patient to feel reassured. And
That's an interesting point. Yeah.
not everybody wears scrubs. Clinical people wear scrubs
Yeah.
because if you need a clinical question answered, you go to them. But if you just need to know where the cafeteria is, she's going to help you or he's going to help you.
They have
Well,
different
we
color
have,
scrubs now.
I was
Like
just going to say, yeah,
I have a
color
pair
code,
of
but
green
patients
scrubs.
aren't going to know that.
I have a pair of green scrubs that I try not to wear at the hospital because that's the respiratory therapy scrubs, and I keep getting called for respiratory therapy.
Yeah. And then the other thing is, I was trained that scrubs belong in the OR or at nighttime when you're on call. Other than that, physicians didn't wear scrub. And if you were caught with a scrub at 10 in the morning walking through a hallway, somebody would say, that doctor, that's for the OR. You're not in the OR.
I'm wearing it on the podcast.
You always wear it on the podcast. But
Well,
I think as humans, we need some signaling that says, who's the person's in charge. That's why the military has uniforms.
I think about Mr. Rogers when he would come in and he'd put on his sweater and his tennies. It was like you said, a signal. I hadn't really thought about that, but I think that's where you come dressed to work. And there's something to be said about when I was doing administrative work. I had a different wardrobe. I had power pumps and I wore different clothes because in order to feel like I have to,
Play the part.
if I showed up in scrubs to an executive meeting, it's just like you needed to do that. But anyway,
Yeah. I think we forget the perspective of the patient. When you're in the hospital,
yeah,
whether it's you're in the hospital, your family members, you're extremely stressed. Anything that is routine
yes.
is one less thing that you need to stress about.
I love our podcast friend, Scott Grant, Docs to Dad, says, I have to remember that when these patients are in the hospital, this is their worst day. For me, it may be, oh, it's just a dehydration. They just need some fluids. But for them, this is their worst day. And I need to remember that. And you're right. I'm the one that's reassuring them that we know what we're doing.
Yes. After residency, you joined Rambling Road Peds, which is a Bronson Hospital, Bronson Health System owned practice. Interestingly enough, Bronson's been owning practices for 30, 40 years now, way before it
Yep.
became fashionable.
Rambling Road was the first practice that Bronson bought in 88.
What are the pros and cons of always having worked as a primary care pediatrician within a huge health system?
I never have been in private practice like George, so I don't know what but I can tell you what pluses and minuses for me were. One is like the hiring and firing and the business piece of it was not my forte. And so I didn't have to do that. The downside was because of that, people are telling you what you need to do to make money because you have to pay your bills. And so you worked for a contract and it's not your own. And however, I do have to say, I think for as much as we fussed about productivity, we were able in our practice to maintain the clinical calls so that we would say, this is what we need to do for clinical care. This is what we need to practice. And we were able to maintain that power. And so I think that it made a big difference. And in fact, like with COVID in our practice, everybody's trying to figure out what to do. And we came up with our own protocols and we would follow the AAP interim guidance. We'd make changes. And because the hospital system was slow and we're like, we don't have time to mess around with this. This is what we need to do. And then we need to flex it. But we also have the part of the hospital is that they can afford to do things like pay for Epic and do those kinds of things. We also had the luxury of having social workers in our practices and the hospital bore the cost of that. And that was a game changer. Every pediatric office should have a social worker. It just should be a thing. It makes all the difference in the world. So I think those are the pluses and minuses, just the trying to figure out RVUs and how you're getting paid. And that was, you want to feel valued because this is hard work. And when you feel like the administrators don't really, they haven't walked your shoes, but they also have different decisions they have to make. And yeah, that's what I can tell you from my end. But like I said, unlike George, I haven't done private practice. So
Those
that's my
administrators
only
used to
experience.
walk your shoes when they were physicians. Today's administrators are not physicians. They're suits. What do they know? What a pediatrician needs or an internal medicine needs. Physicians need to get back into the administration roles out there.
We do have several physicians that are in lead positions in the hospital. A lot of the senior staff was also nursing staff. It's a different relationship. And so I think you're right. But the other thing that was really lacking was women physician leaders. And that was still, when I was doing administration, I was one of the few women in an administrative role. Still had to fight for it. There's still a glass ceiling.
I've seen women leaders. They were usually nurses or suits.
Yeah.
I don't think I've seen women. You know what? Other than Dr. Coronia,
Well, yeah.
I don't think I've seen a physician leader that's a woman.
I would say your
Yeah.
wife's a vision leader.
Yeah, she is.
Yeah. Like,
But she was an employed physician of the hospital, so she really didn't lead anything. She followed.
I was
I
always the person at meetings, big meetings with all the administration. I'd say, where there's no women in this position. There are 13 positions. There's one woman. Why is that? Because look at this audience.
yeah.
You know,
Politics of it get to you, or is it Bronson seems to have a pretty healthy, mission-driven culture?
yeah, and there's been a big administrative change. Our CEO, who had been there for a long time, changed, and the poor guy that took over started like March 1st, so in 2020, and
Oh,
so everything was different then. So there's been a big switch over. So I don't know. Being in administration my last 5 years, I was in administration as a medical director for behavioral health, which was a role I made up because there was nothing. And yeah, it was hard. It was really hard. I think part of it is as physicians, we're like, I got to make 25 decisions a day. And I can't say, let's have a meeting next week or next month. We'll talk about that again. And we need to have all these other meetings. And oh, did you invite? Why isn't this person here? And I'm like, I don't know who that person is. It's definitely an inner club. And it was frustrating. It was frustrating, but I felt like the work was important to do. I hung in there for a while, but then I just was
you
like,
can ignore the torture of the inefficiencies and
yeah,
that
yeah.
endless meeting where nothing gets accomplished.
Because I believed in what I was doing. I knew we needed to have suicide prevention. When I took the position, we had 17 policies for suicide prevention, and we just didn't have protocols. And so we did trainings, and then we built in integrated behavioral health, started with 6 social workers. By the time I left, we had 30 in all the
Okay.
primary care practices, and we trained them and we built that program. So I was really proud of that.
Yeah, that's a wonderful achievement. Now, would you mind sharing with the audience who Mark Sloan is? And
Oh, he's a giant. He's a wonderful human being. Pediatrician, DO, was down in this little town in Dowagiac. He did a national service, so he had to commit to doing his first years in practice in a rural area. And so he was managing everything. He was doing there was a small community hospital. And then he joined our practice, and there were 5 of us at the time. I was the only woman in the group, and he's hilarious. So we had lots of fun. And he just had this incredible interest in mental health and availed himself of lots of training. And he just really learned a lot. He had a passion for trauma, adverse childhood experiences before it was a thing, and loved his patients, was just a critical thinker and a huge mentor for me. Just a great friend. So I learned a lot from him. He was just an amazing clinician. Still is. He has He's done a lot of grant work and really working hard to help people recognize that when traumatic things have happened to kids, they behave in ways that are difficult.
so when I was there, he was from somebody coming from Washington, D.C., way in the booty, right? Because he was in a very small town. but he used to drive to Kalamazoo once a week, and he started an attention
Mhm.
deficit disorder clinic. And I was so intimidated. I'm like, I'm never going to treat ADD in my office. Never. Because he did a whole workup. He really was like, it was a whole day thing. The kids were in there for a whole day being evaluated. And I'm like, you can't do that in 30 minutes. It can't be like Mark Sloan in 30 minutes. It's impossible. So he's a phenomenal human being and very funny.
Yes. Yes.
Um,
Very funny.
Now you followed your passion for pediatricians and mental health through Bronson as a director there and wearing many hats at the AAP in Michigan and now the National AAP. How do you keep that passion for pediatricians?
With the AAP, I started at the chapter level. I had always been an AAP member. It was just like, I just thought that's what you were supposed to do. So I've always been an AAP member and of my chapter as well. And our president at the time I was in practice they would go around and do these focus groups around the state, meet in different areas. And so I got interested in the chapter, but at one point I was doing a conference and maybe I'll see if the mental health committee, we can partner up with the chapter and they could be a sponsor. So I called the chapter and there wasn't a mental health committee. And I said, could I start one? So I was a committee of one. And then someone asked me, there was a vacancy and they needed somebody. And they said, would you be interested in being the vice president? Which meant that I would do 2 years of VP, 2 years of president, 2 years past president. As a VP and president, you get to go to the annual leadership forum that's now called the Leadership Conference. And that's where all the presidents from the chapters and vice presidents come together and talk about the field of pediatrics. They debate resolutions that come from everywhere. And it was the most incredible experience. I loved it so much. I got to meet these people who are so passionate about pediatrics, and anybody could put forward a resolution. At one point, I put forward a resolution that made it into the top 10 on suicide prevention. And now we had a summit. And so things happen because people care about it. So once I sort of drank the Kool-Aid, if you will, I just wanted to figure out how to stay in. So I was on the national nominating committee, which was fabulous. I get to meet all the people who are interested in running for president of the AAP, and they're like the most incredibly brilliant people. And then there was a board seat open for our district, and I ran for that, and I'm on the board, and I love it. Chairing the policy committee this year, which is fascinating how policy happens at the authors that take their time, they're volunteers that write these policy statements and clinical reports, technical reports, clinical practice guidelines for our organization and for the world.
So
I love it.
I'm going to interrupt you a little bit. So, what is the difference between a clinical report and a practice guideline?
They're different the way they develop. A policy statement is a policy of the AAP. It's more aspirational. And it includes recommendations. A clinical report is clinical guidance. It may be recommendation, and they're recommendations. A technical report is really more supportive. It's much longer. Policy statements are short. A clinical practice guideline is a different process because it uses the standards of the grade where you have the strength of the recommendation, the evidence, that kind of thing. And it goes through a different process and they take longer to develop. So it's a little bit different process, the products that come from the AAP. And the policy committee, we work with the authors to make sure that it's as good as it can be because a lot of the times there isn't the research in kids. And so we have to use the best evidence that's out there and to try and help each other do the best job that we can.
And for example, a clinical report would start out at a section, like maybe section sports medicine or mental health or endocrinology. And then it would be shared with other committees that might overlap,
Yeah.
right? Then it goes up to your subcommittee and then to the full board, and then the recommendation is made.
Yes, but in between there's all the other reviews. So if it's something that comes out of the Council for Children with Disabilities, for example, they may have as reviewers, the Council on Adolescence. They may have the section on pulmonology. So there's all these reviewers. So there may be 10, 15 reviewers from other committees, councils, or sections. So it takes a long time, but they've got this incredible breadth of expertise. And then the authors have to address the concerns of these folks. They all get looked at by the risk folks, the Committee on Practice and Ambulatory Medicine, COPAM, and Child Health Finance. So every policy has those reviewers as the base. But then there's a whole bunch. There are like 90 committees, councils, and sections.
Oh, wow. That's a lot.
Yeah.
No.
A lot of people are volunteering their time. Those are all volunteer pediatricians. It's pretty incredible, to be honest.
Well, yeah. Why do you think pediatricians, moms, and children are suffering so much today?
It's a lot. As I said during the hour here, it's a hard job. And when you want to have a family, and I think the other thing that the folks coming in now that I didn't have to face is just the incredible debt. When you come out in debt of $250,000, it's a house. I had $28,000 in debt now, and it took me till I was 40 to pay it off. My salary when I started was 50,000. So
Oh, wow.
yeah, it was way back in the day. And yeah, I think that's really hard. I do think there's a lot more opportunities to do part-time. I was one of in my group. I was the only woman. I just said, I have 2 kids. I cannot do this full time. Can I do it part-time? And it's a maverick there. In our residency, Dr. Tammy Drew and I were the first 2 residents to ever be pregnant. We didn't have any policies. We had to fight for leave. So I think those are challenges that women physicians face in having kids. And how do you make it up? I had to make it up later when I took 8 weeks off because I had a C-section. So yeah, so that was, it's a challenge to do everything.
So
I've
today,
seen in our practice where we had lost a couple of physicians after they had a baby. They just
Mhm.
gave up their careers, which I don't know. I think you work too hard to give it up to take care of babies. And then you come back when you're 40, they're
Right.
going to ask you, what did you do all this time?
Well,
Your
I think
skills,
part of it is finding
a
how do
balance.
you make it work? How do you
You're
make it work?
part-time.
And yeah. And for me, part-time was fabulous because I
Yeah.
got to be a mom and I got to use my clinical skills and I have an incredible husband. My husband was Mr. Mom. My kids have such great memories growing up because they went to city commissions with meetings with their dad. There's just lots of lovely things. I did a podcast with my kids called Cool Dad, Anxious Mom because my kids are always like, "Oh, daddy's so cute." I'm like, "Hello, what about
yeah.
me?"
Yeah. Now, my wife worked her entire career in the emergency room part-time. It's a very interesting thing. She got her job. She worked in a small private practice for a year. They wanted to sell her to practice. She wasn't ready. And she was pregnant. Her contract expired. And they said, don't come back tomorrow. She was like 8 months pregnant. We're not going
Oh,
to renew your contract. Try doing that today. Then she worked after she had our first son, a couple of months later, she wanted to get some kind of a part-time thing. She found it at the university center. She didn't like driving and all the academics and all the bureaucracy. So she quit that. And then they were opening up the pediatric emergency room Dr. Crony was opening it up. They were looking for physicians. So I went to the director and says, don't you know somebody who knows somebody that can get my wife a job somewhere? He says, just so happens that we do. We're opening a PDR. And they were taking general peds at that time. So she went, she interviewed, they liked her, they offered her part-time. Went back, the guy meets me on the hallway and says, so what happened? Says, yeah, she wanted full-time, but they were offering her part-time. I said, listen, let her take part-time. It's the best thing for you, your family, your kids in the future. You have kids. She'll be there. She'll still keep her skills going. And if she needs to buy something, she wants to renovate the house or buy furniture or something, take a couple of extra shifts. There's always money to be made with extra shifts. This way you only commit to part-time. She did that her entire career.
Yeah. Part-time for me was great. And when my kids were older and I took a full-time position so I could flex it, which
Yeah.
was really nice. And I have to give credit to the Bronson administration for letting me do that and making it possible.
It's interesting. You mentioned student debt. From my perspective, I think the lack of payment for primary care is a big reason why there's so much suffering right now. It's just, I understand that in Michigan, pediatricians starting out at 120,000 a year. The bus drivers in DC make $90,000 a year. So you cannot invest 11 years on your youth into a project and be paid the same as a bus driver. It's not possible. The student debt is a problem, but I also think these younger people don't feel the accountability that we might have felt. They spend money on student loans like it's a salary. And I don't think anybody sits them down and says, look, as a medical student, you shouldn't really be having a 1 week vacation to Europe. That's what you do when you save some money and you pay for that cash, not on a credit card, but on cash. And because getting out of that hole, some people are in $300,000 in debt before they
No,
start
it's just
practicing. That is
insane.
extremely difficult to do if you're not making $500,000 a year when you start.
That's what they say. After you graduate residency, live like a resident for another 3 years with an attending salary and pay off your loans. During COVID, we have some physicians in the office that had student loans. So they put a pause on payments, right? So I have doctors that had a pause on their payments. What would you do, Herb, if you had a pause on 200,000 during that time and you were making money?
I try to pay that loan down because it would be
Exactly. Pay that
realistic.
loan down, and then when the interest comes back, you would have knocked it down. They put a pause on payments, so they didn't pay anything. Interest comes back, they still got that nut to crack. Nobody teaches them these things.
Yeah, I think that should be part of medical school or,
No, there's nothing.
somewhere undergraduate about how to manage finances and how you're going to pay for things because it's hard. My husband was a PA and he had school debt. I had school debt. We had no money. We had old houses that we renovated. We did everything ourselves. It's weird. I don't know how we did it back in the day. We just didn't have any money. We had to do it ourselves, even though I was working full time and he was working. But yeah, everybody has to figure it out. But I think having some acumen about how to do it. And I know that there are some things available through the AAP to help educate people. I know the section on pediatric trainees, they do a lot of stuff. The section on early career physicians, that they talk a lot about finances. So there are resources out there, but I think people need to know what they're getting into.
Yeah, so I'm gonna give a shout out to two people that they are AAP members. They're both in Rochester, New York. And I think Kathleen Wania, and I will not butcher Jeff's um, last name, but Jeff's, I think, is also on the board of AP, new member. And they're so passion driven to take care of children who have less resources than most of us do. And they have been working and doing yeoman's work with the state of New York. And they, through their waiver on the Medicaid side, they have gotten through three proposals, which I think are incredibly important and should be emulated across the country. The first proposal is that all MCOs need to pay pediatricians a base for fee for service. Because right now in many states, the MCO out of Minneapolis that employs 100,000 physicians will pay $45, $50 for a visit on a Medicaid patient in New York, while they're still getting the same $200 a month from the state of New York that the other MCOs get to provide care for children. So in Virginia, that Minnesota MCO, the Blue Cross Blue Shield MCO, the Aetna MCO, they all have to pay 80% of Medicare fee schedule, fee for service to the clinician, which is the way it should be. That money is meant to take care of children, not to pad the salaries of the executives in Wall Street or Minnesota. The second one that they did, which is also genius, doesn't go far enough for me, but I understand why they're doing it. They have set aside $100,000 per pediatrician that stays in a community practice and sees at least 30% Medicaid or uninsured children. I wanted to go further. I think access to a pediatrician is like access to a public school, which means there is no means testing. Nobody says, George, how much money do you make? You're not entitled to send Peter to this public school because you make too much money. But I understand this is a Medicaid waiver, so they have to play within those rules. But that is a huge win for the pediatricians of New York because these other programs of loan forgiveness are tied to working for a health system or working for a federally qualified health center, which usually happen close to a big hospital because they're the only ones that can take the administrative costs of doing this.
Right.
And the small communities that really need mission, passion driven pediatricians, and they can only afford one or two doctors and they're independent, weren't able to be part of this loan forgiveness. And I think this is a phenomenal win for the New York pediatrician and something that we should be pushing to happen in every state.
I think it's important because I have yet to meet the medical resident that's graduating that's come in for an interview that does not have student loans in excess of $200,000. They just don't exist. It was interesting. Last week, we interviewed this one fella. He graduated medical school in Nigeria and he's looking for loan forgiveness. And then after, like, he was leaving, and I said to him, I says, I don't understand. How do you need loan forgiveness if you went to medical school in Nigeria? There was a reason for that. He had to do an MPH in order to be able to, because he was a former medical graduate. In order to get residency, he had to get an MPH first for 2 years. So he put a lot of money into that. So it's a student loan.
Yeah.
So
But
everybody has student loan.
yeah, but the problem from an access to care and equity point of view is that private equity, the big health systems, the empire from Minnesota, who now employs 10% of the US physicians, is not going to go into the urban, rural, or suburban deserts where 80% of the kids are on Medicaid and start a one or two person practice. Only an independent physician, and we hear it all the time in your neighborhood in Brentwood, is Juan Espinosa,
Yeah.
the son of an immigrant from El Salvador who started the Dr. Spinoza, number one, senior, started a pediatric practice in a Spanish community, in an indigent Spanish community, in an indigent Spanish speaking community.
Correct.
And he's from El Salvador. And his son comes in, joins the practice, keeps the legacy, stays in the neighborhood. One could have gone to Manhattan, or he could have gone to a fancy suburb of Long Island to practice, but they're committed to that community. And there's no way the hospital, the private equity, the people from Minnesota are going to invest in those small practices that are serving those communities that really need. And we do everything we can to maintain those independent practices open and thriving, because that's the only way these less fortunate children get access to a good pediatrician. And that, I think, that's why I'm so happy about the work Jeff and Kathleen have done in New York.
They could go to 45 minutes east to the big university or 45 minutes west to the other university to get their vaccinations, which is not
That's
going to
not,
happen. Or they
that's not,
could go to they could go to the federally qualified health center down the road in Brentwood Road that opens at 10 until about 4, and you can't get an appointment. God forbid you're sick. You go to emergency room. 3 patients a day.
yeah. No, I think it's phenomenal. I think I'm very
No,
happy.
Dr. Espinoza is brilliant. He does a really good job for the community, and without him, I think the children of Brentwood would not survive. They may come to our office. He's the real deal, and that's why I call him the Godfather of Brentwood.
Yeah. But it's a wonderful story just from a
Yeah.
family story, right? He grew up with some of these kids. He went to that high
Yeah.
school. And I don't know, he's probably seen the great grandchildren of the people his dad saw. And there's such an important thing to be part of the community and understand the people you're taking care of because you come from a similar place. I don't buy much into that. I don't really care if it's a woman doctor, what color the skin is, what gender they are. I don't really care. If I'm sick, just give me the best doctor. Take care of me. But when you're building relationships, people do appreciate that you understand where they're coming from and that you have shared a similar immigrant path they have. And that's very valuable. That's part of the secret sauce of
Yep.
so I'm incredibly grateful for the work Kathleen and Jeff have done. And I think we should all applaud their work. Leah, tell me
Yeah.
about your podcast. I'm a big fan of your podcast. Why did you start it and how much do you love it?
Oh my God, it's so much fun. So, just in a nutshell, I was on a podcast, Mighty Parenting, talking about suicide prevention because that was an area of expertise. And I thought, God, this is fun. I could do this. And my daughter's boyfriend at the time had a podcast management company. And so I started talking to him and helped me figure out like what microphone to buy and things like that. And so during the pandemic, I had some time, made some changes in my job. I had retired from, I was still doing on call, but I had more time. And so I said, gosh, I would love to do a podcast on children's mental and emotional health and talk to people about stuff that I wish I'd known. So I tell my guests, I imagine I heard you speak at a conference and then I got to sit next to you at lunch and said, gosh, tell me about what you do. And people like talking about their passion. I'm almost at 180 episodes. I do an episode once a week. And yeah, it's been fabulous. And because it's my podcast, I can interview who I want. And so sometimes it's not always specifically on mental health. I've done a lot on physician mental health and well-being, but you name a topic. If I hear somebody interesting, I'm like, would you like to do a podcast? And so this month I did a series on trauma with some amazing people, Dr. Ed Tronick, who did a really famous study called the Still Face Study, Andy Garner, who's a kind of a champion of adverse childhood experiences, toxic stress, and resilience, Brooks Keeshan and Jessica Griffin, and then Judy Cohen, who created Trauma Focused CBT. And then next month, I'm doing a whole series on social media. And that's been really cool talking about that and just some of the things that we're talking about. But like I said, I get to do what I want. Sometimes I do my own. I'm going to do a series on implementing, it's going to be called Pediatric Mental Health Building Better Workflows. And it's going to be a how to 12 podcasts on you want to implement change in your practice. And I'll have a downloadable workbook. And so that's what I'm working on.
And would that be a limited series or it'll just be with
Yes. It's going to be a separate podcast. It'll be a limited series of 12 episodes. And yeah. And so I'm interested in consulting. I would love to work one on one with people who are interested in changing their work practices. So yeah, so I do that. I do some consulting to the University of Michigan Child Psychiatry Access Program called MC3. So I get to teach physicians across the state on suicide prevention. We've done 2 Echo series. We're going to do another one. And then I'm on the board. So that keeps me pretty busy.
Wow, that's phenomenal. I love your podcast.
Oh,
So
thank you. It's big fun. I love talking to people. It was my social life during the pandemic.
Maybe we should introduce her to Dr. Riley and Dr. Nick with their ADHD program.
yes, absolutely.
How you can do it in private practice.
Yes.
Yeah, I find my guests by either people I've heard or like when I was doing something on substance use and Susan Wally, who was the chair of the section on tobacco and nicotine, came on and did something on that. So because I've got to know people across the country, if I don't know someone, I know someone who might know someone. And so I've had incredible leaders. I did a podcast with Joe Wright, who's now our Chief Health Equity Officer at the AAP. He's just brilliant. So yeah, it's been big fun.
Yeah. Yeah. It's a wonderful podcast. And they can send
Thank you.
they can find you on Apple Podcasts and Spotify.
Yep. Yep. It's called Pediatric Meltdown. And you can see my logo, which I love is the melting ice cream cone because we always talk about kids having meltdowns. So that's where the name came from. And so, yeah, I have a great new website called pediatricmeltdown.com. And you can easily search episodes. So you can look on Apple, but it's easier to search through the podcast or through the website. And I have merch now. I have merchandise, and I also have a book. I have a book club. I list books that I like or books that my guests have written. And yeah, it's fun. It's brand new website. And
What the teenagers do.
Merch.
yeah,
What do you
merch.
have? Hats and hoodies?
You can get a mug, you can get a t-shirt, you can get a notebook with this cool logo.
Well, we
I'm
got a new
trying to figure out
Pediatric Lounge merch.
I'm trying to figure out how to do onesies. I'd like to do onesies and sippy cups. So that's my goal, figure that out. But yeah, it's a cute logo. You can get a tote bag. Anyway,
That's
Well,
pretty
so
cool.
yeah,
That stuff.
I like it.
yeah. So check it out. Check it out.
Wow.
Leah, what have I not asked you? What do you think is also important for the audience of pediatricians that listen to the podcast to know?
I just be really proud of what you do. It's an important job. Kids, if not us, who? And I know that there's so many demands on the work that we are asked to do, but I don't know. At the end of the day, it's such important work. It just fills my cup, and I've loved doing it. It's really hard. And so you have to figure out how you're going to take care of yourself. But doing like this, getting to know you, George, and reconnecting you with Ferb, this is what brings me joy, is networking with other pediatricians. Absolutely. Absolutely. The trauma response is Heather Forkey. Great podcast, by the way. The trauma response is fight, flight, freeze. And the other is affiliate. And affiliate is what we do to survive. And we're pack animals. And
We should also introduce her to Dr. Mark Lerner, because he does a lot of the trauma work.
Yes.
Yeah.
And as Wendy Hunter said, find your battle buddy so that you have somebody to decompress with that knows your experience.
I love Wendy Hunter. Boy, do I love Wendy Hunter.
She's great. She's great.
She's phenomenal. And yeah, and her podcast is phenomenal. And the thing she said,
The pediatrician next door. So yeah, I've interviewed several podcasters. I've gotten to know, I think there's 10 of us. That one of my friends, Elise Faluco, who's a child psychiatrist, just started one called Psyched for Peds. And she does little mini episodes from a psychiatrist point of view. And so it's Psych ED for the number 4 Peds, Psyched for Peds.
Right.
I mentioned Scott Brandt, Docs to Dads, of course, the Pediatric Lounge, the Pediatrician Next Door. So those are just a few.
Yeah.
Oh,
know
and
those two guys at the
Carrot
lounge.
Talk.
I know those two
Carrot
guys
Talk.
at the lounge. I can hook you up with them too.
Leah, thank you so much for your time. Thank you so much for everything
Oh, it's
you've
been a
done
joy. Thank you.
Thank you.
I love
for
it. It's been
pediatrics
fun reminiscing.
in the U.S. And I hope to see you at the AAP Michigan chapter or CME conference this fall in Kalamazoo, Michigan.
That would be wonderful.
And Kalamazoo in the fall. It's a wonderful
I can
time.
take you out for a caipirinha, our jungle bird.
Oh, definitely. Not just one, two. I hope to see you there. Until then, take good care of George, your husband, your daughters, and yourself. And lots of love. Thank you for everything you've taught me
Thank
through
you.
the years.
Thank you.